So I'm very honoured to have Dr. Ralph Audehm here today. I never say his surname correctly.
Yeah, Audehm's fine.
Audehm's fine.
Right.
As I said, I met Ralph when I was working in the primary healthcare sector. He gave a talk to GPs about diabetes, and I learned then that he was with Diabetes Australia Victoria, just down the road actually. They've got their office, and that prior to that he was a general practitioner, but he's one of those unusual general practitioners who really is interested in public health, and I was most impressed by his presentation to the general practitioners in sort of advocating that they get into public health beyond their offices, beyond their clinics. As we all know, most general practitioners will stay in their room all day and we go to them. And one of the inspirational things about Ralph is that he goes to people. He has done a lot of work in the diabetes field, giving lectures, starting up significant programs, and in really outreaching into the community for the benefit of a lot of other public health conditions. Since being with Diabetes Australia Victoria, he's now moved to become a community health general practitioner, so not in a private practice as he was before, and is now doing a lot of continuing work, not so much now in diabetes as I understand it, and he'll probably speak to that. I found him to be an excellent presenter, and I'm really pleased that he could come along today and speak to you all about medications and how many there are, how they're being touted to GPs, sold to GPs, and I don't know what else you're talking about, but I'll now pass it over to Ralph. Please welcome Ralph.
Thank you for asking me to talk about a topic that's very close to my heart. And look, I labelled it just another pill because, in fact, a lot of what I do is, in fact, adding in medications. And certainly for diabetes, as we'll learn a bit later on, that can be a good thing. But, I think as you start putting together your thoughts around this, there are other issues that tend to come into play. So this is more about, I suppose, a look at how medication is actually being used within primary care, and really some of the problems and some of the benefits that we get. So, just to remind, these are more to remind me, the number of medications that I can prescribe are growing at enormous rates. And even within a class of drugs, the number of brands that I can prescribe is actually growing faster and faster, and it makes it really interesting trying to keep up. Polypharmacy, i.e. taking lots of medication, is becoming the norm. Now, I'll show you some stats from real-life practices about that. So there is this tension between having lots of medications in terms of being a benefit and then lots of medications and causing a problem. And again, I'll hope to show you some stats around that. But one of the things that's really missing is that we actually don't have lots of studies in elderly people, however you want to define elderly, in elderly people who are taking multiple medications from different classes. So when we look at research, we're often looking at a single condition in a group of people, and often all those other conditions are excluded. So when it comes to having things like diabetes, heart disease, lung disease, all coming together and prescribing simultaneously, we don't have a lot of evidence about that. So as GPs, we really do fly by the seat of our pants. The other thing that I'm going to highlight is the expense of new medications. New medications are really expensive. And I'm going to show to you that, in fact, for that expense, some of them actually aren't even as good as some of our older medications. So, again, these are some of the interesting things. But at the end of the day, responsible prescribing and responsible use of medication is something that's going to face everyone. So what I thought I'd do is I'd show you a little bit about my practice. So I work in Broadmeadows. It's a low SES area in the northern suburbs. Yes, I'm a community health doctor for the first time, which is interesting. But you can see that we have an older population. So from above there, we're talking about 45 and above. So predominantly an older population. Now, this is looking at our regular patients. Now you can see here, only 26% of my population of patients take no medications. 1 in 4. I mean, does that surprise you?
No.
It doesn't? I mean, I'm thinking, gee, 25% on no medications, I would have thought it would have been far more. Because again, you think of all your young people, you know, I mean, more than 25% of our group would have been less than, you know, 30 years of age.
Oh,
Yeah.
sorry.
Yeah, no, that's right. But looking here, you can see here that about 20%, right, of the whole population that come to my practice are taking 8 or more medications. 1 in 5. Okay? So that's looking at the whole population. Now, it wouldn't surprise you that if we now look at the sort of medications that people take, the biggest group would be these 3, which is for high blood pressure. So high blood pressure is the most common thing that we treat, and that's where we get a huge amount of them. Now, someone in the audience asked me, are we prescribing too many statins? If you look at this one, 20% of my whole population are on a statin. A statin's a tablet that we use to lower cholesterol. Now, are we prescribing too much? We can talk about that later on, and I think it depends on your viewpoint. From a GP's perspective, I think we are, but cardiologists will say to you, no, you know, add it to the water. Now if we start to look on as people get older, right? Remember we had about 20% on 8 and more medications. In the over 60 group, see this great big wedge here, 45% of people aged over 60 are taking 8 or more medications. I mean, that's huge. And you can see only 6% are on nothing. I mean, you know, so things have really changed as we've gone older. Now, managing that, not only the expense of it, but even remembering how to take things properly starts to become an issue. And again, same sort of things. The biggest, these 3 are all used for blood pressure. Now, people may be on more than one, which we can talk about later on. But again, look at the lipid modifying. Half of the people over 60 years of age are on a statin. 50%. Now, 50% don't have heart disease, I can tell you now. But again, just something to highlight. Antidepressants, again, 18%. So, we know, and we have seen a huge growth in the number of antidepressants that we use. And in terms of, you know, platelet things that we use to thin the blood, you can see there's nearly 50% of people taking something to thin their blood. So, what happens, do you think, if you have a chronic illness to these figures? I'll show you. Right, so as you hear, I have a real interest in diabetes. I've been doing diabetes since about '94. Look at this. This wedge are all the people with diabetes who take 8 or more medications. That's a whopping 62% of people with diabetes are taking 8 or more tablets every day. I mean, it's huge. And you can see there's no one on no medication. All right? So, I mean, some of you in this room will be facing this sort of issue. I mean, you'll be going to your doctor and he'll be adding more and more medications. Is it a good thing? Got no's? Does anyone think it's a good thing?
If you're a pharmacist.
So again, within that group of people with type 2 diabetes, again, the vast majority, high blood pressure medications. Again, 3/4 are on some sort of tablet to lower their blood glucose, which is what we would expect. And then again, you know, nearly 70% on a statin or something to lower your risk of a heart attack. So, is it a good thing? So this is, of all the trials I've ever had to talk about, this is one of the most fantastic ones. It's called the STENO2 trial. It's for people with type 2 diabetes who have problems with their kidneys from the diabetes. Okay, so we know that once you start getting complications of diabetes, especially kidney disease, you're in strife. All right? Now, what they did, they took 160 patients, they treated 80 patients as they would normally, and the other 80 they just gave them drugs. All right, we gave them lots and lots of drugs. So they all got a statin, they all got certain tablets to do with blood pressure, they all got aspirin, they got everything. Okay? Now what do you think happened to those people who were given all those drugs?
God.
Well, I'm sorry to disappoint you. Those people that took all those drugs had, they had a 30% less risk of dying, but their rates of complications were halved. All right, so this was fantastic for me, all right, because I could go out there, talk to GPs and say, for people with diabetes, the more drugs, the better. Okay, that's what I say to my patients. And the problem being is that, of course, with diabetes, you have a whole lot of problems coming into play. You have the problems of the actual sugar itself, causing problems with the eyes, the kidneys, the feet. You have problems with heart disease. So the biggest reason for problem, or the biggest issue for people with diabetes, in fact, heart disease. They have to have all those drugs to do with heart disease. And of course, the vast majority of them will have high blood pressure. So you then have all the drugs to do with high blood pressure. So by the time you add them all up, you can see how they just accumulate so much. But that trial was done in 2000, or reported in 2003. Since then, we've had a couple of trials, and one of them was a real issue. This was the Accord trial from America. In America, what they did, they wanted to know how intensive, how hard should we treat our people with diabetes? And so they went absolute hell for leather, did everything they could to get these people's blood glucose down almost to that of a person who doesn't have diabetes. Have you guessed what happened? They started dying. Seriously? No? You should, I was waiting for it.
It's really not that funny, guys.
But this was the first trial ever that showed an increased mortality by managing people with diabetes. And you can imagine the ripples that it caused across the medical profession. At the same time, two other trials did a report, but they actually came out neutral. No increased death rate, no decreased death rate. I mean, they had a decreased rate of complications. So we then had this huge issue. What was it that killed these people in this? It was a very large trial, 10,000 people. What was it that caused it? So what do you think it was?
Statins.
No, not quite. No, in fact, it was because the other two trials had similar targets, but what they did is they didn't treat it so aggressively. So in the Accord trial, what they tried to do is get people down to normal very quickly. So they just kept adding in tablets every month without fail, more and more and more and more. And so what happened was that these people ended up having huge swings in their sugars, lots of hypos, and then they had an increased risk of heart attacks and death. So the moral of the story is, yes, it's good to treat people with diabetes with lots of medication, but you do it slowly, right? You don't rush in. Okay, so that's really important. So that's one thing that we did learn from the Accord trial. So it's interesting how that sort of has changed our view of how we actually intensify medication, because part of the problems I have is, in fact, with getting GPs or doctors to actually intensify medication when they need to. Now, to say that things are becoming confusing, to say, well, it's such an understatement. We now have drugs that tackle type 2 diabetes in so many different ways. So, we had our very first drugs, which were metformin, which has been around for, well, actually we had insulin before anything. And of course, we give people insulin, then we developed metformin, which worked through the muscle and the liver. Then we had sulfonylureas, which came out in the 60s. So, from the 20s to the 60s, we only had 3 medications we could use. Then in the 70s, well, late 70s, early 80s, we had the glitazones. And then, of course, now in the noughties, we have 2 drugs there, DPP-4 inhibitors, GLP-1, I'll talk about, Archibos. We have different insulins that are working really differently. And we have new drugs coming in the pipeline that aren't even on here. So they now have drugs that work through the kidney, that make you pee all your sugar out. I mean, it sounds really interesting. And, you know, well, yeah, I mean, you know, if you want to send it down the toilet, it sounds really good. But, I mean, they will have their own problems. Because, and we can talk about that later on if you want to, but as GPs, you can imagine dealing with this complex, massive tablets, when to use what and how, starts to become a real issue. I mean, even our specialists are struggling with this. So, what the Americans tried to do, they came out with this sort of an approach. Those tablets or medications that have been around for a while, that worked, and we know they worked. And then we had a whole group of tablets, gee, that were interesting, they look good, they were expensive, but we're not quite sure how they went in the long run. Okay, so that's how they divvied it up. And I think it's actually a very good approach. Unfortunately, what we're finding is that some of these drugs down here, because you know they may not cause as many problems like having very low blood sugars, their use is actually exploding. And the use is increasing far more than the evidence tells us to. So we've got no idea what it's like to be on some of these drugs for more than 8 years. So that is a worry. Whereas, you know, metformin, sulfonylureas, you know, things like diamicron, so on, and insulin, they've been around for what, 40 years now. So we know everything about them. So this is my view of the world. So if you have diabetes, you know, you'll be usually on this tablet. You know, so this is, if you look at tablets that we give people with diabetes as the first tablet they ever get. And this change in A1, hemoglobin A1C is a measure of how well your sugar control has been. Okay? So the bigger the change, the more effective the tablet. So you can see metformin, very good, you know, 2% drop. Sulfonylureas, which were the ones that came out in the late 60s, they were very good. The glitazones came out in the 80s, you know, they've got lots of problems, but they did work. Acarbose, which is an interesting tablet that stops you absorbing sugars from your gut. So, you know, it's amazing how innovative people have become in treating diabetes. So, if you don't absorb your sugars, what happens, do you think, with all that sugar goes down to your bowel?
Bacteria increase.
Yeah, so you get fermentation. What does fermentation produce? Gas. So getting people to stay on these tablets was a bit of a problem. And then these new class of drugs here, which aren't very effective, but they actually don't cause any low blood glucose readings. So they're incredibly popular now. But again, no long-term evidence. But if you look at the drug, so remember this, really effective, a little bit effective, least effective. Now if you look at their cost, let's look at their cost. These were the cost of the most effective drugs down here. That was the middle one. And this one, these two here, are the new ones that people are prescribing left, right and centre. So you can see that bang for buck, these were, the older drugs were the ones to use. But of course, when a new drug company comes out, how do you think that they get their place on the market? They bag the old ones. Okay, so a lot of the shine has gone off these tablets when they shouldn't have. All right, so I think that's really important. And anyone who says that the drug companies have no influence on what's prescribed in Australia, I disagree. I think they're wrong. They do. They have a very profound effect. Now, some of it's, not all of it's bad, but yes, it can be expensive. Now, just looking at insulin, this is the cost of the new insulin. So it's almost double the insulin that we used to use 10 years ago. I can tell you now, hardly any of this insulin is prescribed anymore. And yet, we know it works, we know it's safe, but this one just has a little bit better effectiveness, few less low blood glucose, and yet double the price. I mean, this is you know, a real issue that's going to be facing the governments, because the growth of diabetes, as Kerry's going to tell you next month,
Oh, I've been talking about it before.
Yeah, well, as you know, the growth of diabetes is huge. And if the cost of medication is going to be like this, we're talking about nearly $450 per month that the government's paying for this, right, per month. So, big issue. As opposed to this one, which was $200. So, and and where I'm coming from is that's just looking at your blood glucose medications. All right, people with diabetes, you've got your blood pressure medications, and we know after 10 years of diabetes, most people will be on at least 3 different sorts of blood pressure medications. All right, so let's say you're on 3 tablets for your diabetes. That's 3 tablets for blood pressure. That's 6 there alone. Cholesterol, so we know that people with diabetes, their biggest risk is heart disease and heart attacks. So yes, they should all be on a statin. So every person with type 2 diabetes over the age of 50 should be on a statin. I actually agree with that. Antiplatelets, so these are things like aspirin to thin the blood, make the platelets not as sticky so you don't have as many heart attacks. Now there's interesting, we don't know anymore. We used to think everyone should be on them. Then we said, oh, maybe only some should be on them. Now we're at a point where we're saying, well, unless you've had a heart attack, we don't know. So, I mean, where does that leave me? I've been giving aspirin now to people for 10 years. What do I say to them? Well, you might as well stop it because you haven't had a heart attack. I mean, what do you do? I mean, if your doctor said to you, well, you've been on aspirin for 10 years, no longer need it, what would you say? Yeah, you'd be saying, what the hell? What the heck? And this is only for diabetes. Just imagine if they had things like arthritis or epilepsy, or lung disease, asthma. You can see how they just accumulate so much medication. So we end up with a real soup. And yes, I do have patients who say to me, well, if I put them all down at the same time, how do I know the right tablet goes to the right spot? And if you're taking that many medications, I mean, I really don't know, honestly, how you will go if you're taking, 10, 12 different medications, because there's no long-term studies. I can say, well, if you look at those 6, yes, you'll probably do well. If you look at those 6, you'll do well. But if you combine them, we're not so sure. Now, so my big issue as a GP was a thing called therapeutic inertia. This is when doctors should prescribe something and they don't. Now, do you think that's a problem? Yeah. Well, because most people I talk to say that doctors are pill pushers. But in fact, I can tell you within about 50% of their consultations, when someone goes in and it's absolutely obvious that they need to have an increase in medication, 50% don't do it. Isn't it interesting? So, and we know from that Steno-2 trial that lots of medication's good for people with diabetes. So on one hand, I'm sitting there saying, you've got to prescribe more. Now, how does that sound with you? Do you think that's a good thing? I'm telling everyone to prescribe more? Thank you, it depends. And I think that's the real key at the end of the day. Now, this is just a slide showing that even for something as simple as high blood pressure, when someone needed to, let's say someone with diabetes, they need to have their blood pressure medication increased. 25% of the times, that tablet or the blood pressure tablet wasn't increased. So we know it's a big factor. Now, if you look at when blood pressure tablets were first introduced in the late 60s, early 70s, the number of strokes in Australia halved. So we know controlling blood pressure is a good thing. And yet here we have half, 25% of the cases, medications not being increased. In fact, if you look at Australian data, only 50% of people who have high blood pressure have their blood pressure controlled to target. Only 50%. So there's a group of people that I know I have to increase their medications. Isn't it interesting? Hold that thought, because even with diabetes, we have a similar problem. And the issue with diabetes, it's a little bit different. So this is at how bad someone is with their sugars before a new tablet's added in. Now, if you have a target, you would think once you go past that target, we would add another medication in. Yeah, that would make sense. Well, interestingly enough, if you're not on medication, you go above the target, in about 60%, 70% of the times, the GPs will start the medication there and then. Still 1 in 3, they'll wait a bit longer. Interesting enough, if you're already on one tablet and you go past that target, only 1 in 3 will get an extra tablet. So it seems like once you're on something, doctors will wait until you get really bad before you get your second tablet. Now, what happens, do you think, if you're on 2 tablets? Well, I can tell you, you have to wait until you're really, really bad to get on. Now, in the past, that was insulin. Okay, so you went 1 tablet, 2 tablet, insulin. Now, the difference is the target is 7%. The average level at which insulin starts is about 9.5%. I mean, it's terrible. I mean, you know, so again, one of my jobs that I've taken on is to get GPs to prescribe more and more medications. And this is the paradigm that I use for GPs. You know, the way our current approach is that we wait for people to fail before we do anything. And in fact, we wait until they fail really bad before we bring in the really big guns like insulin. And let me tell you, insulin is one of the safest drugs and the most effective drugs for treating type 2 diabetes. But yet, they're going to wait until people are really bad. And I'm sure you would have remembered from 10, 15, 20 years ago, oh, we only go on insulin when you're really sick and you're going to lose a leg or something. Is that what people remember? Yeah. Well, it's not like that. And in fact, there's a debate now whether we should be using insulin at the very beginning. Some smart chap in Italy got all these people, first time diagnosed with diabetes, put them on insulin there and then for 6 weeks. Some of them up to 3 months, but 6 weeks intensively on insulin. Have a guess what happened? They did. Their diabetes disappeared. They stopped the insulin and their diabetes disappeared. And in 1 in 3 had not come back at 2 years. So, you know, there is something about insulin that is good. Okay? And what they think is that it rests the cells in the body that produces insulin. Now, it hasn't come into general practice yet, but gee, you know, can you imagine, oh doctor, you know, I've just been diagnosed with diabetes, oh here's insulin. How would you respond to that, do you think? You'd be shocked, wouldn't you? So there's a lot of work to be done around that. But anyway, so this waiting for people to get worse and worse and worse before we do something's wrong. And we need to reverse that. But we do need to temper that. So that's just all using the same thing. So that's the doctor side of things. But do you think patients want more medications? Yes. They do?
No.
Oh, well, in fact, evidence would tell us that when we give someone a medication, that 50% of them won't take it. Isn't that interesting? I mean, I can't believe it. I can't believe that my patients don't take tablets that I prescribe. But research has come time and time again and showed that this is the case. So, why do you think that is?
People hate doctors.
Oh, they couldn't hate me.
I'm just saying there are certain people who really do distrust doctors.
Oh, absolutely. And actually, I don't mind those patients because you end up having a good dialogue about why they should and shouldn't, and it becomes their decision. But yeah, so that, you know, adherence, sticking with the tablets that we give you, is only about 50% of people who have a chronic condition. 50%. Now remember that statin. Who was a statin person? If you give someone a statin, 50% will stop within 6 months. Fascinating stuff. I mean, you know, and to me, what I'm interested in is what were they prescribed for? What were they told? Because I do think statins are being overprescribed. And remember, if you're giving someone a statin, this is a tablet to lower cholesterol. It's really there to prevent a heart attack. So if you've never had a heart attack, you don't have angina, you know, you're taking a tablet and you're wondering, well, what am I taking it for? So there's all sorts of issues that come into that. Cost, especially where I work, is a big issue. Now look at this. This is from the National Heart Foundation. People with high blood pressure who take their medicine less than 20% of the time are twice as likely to be hospitalised. So we do know that, you know, medications are important. So sticking with them is really, really important. Well, actually, that was a good one. That was those people who take, if you've had a heart attack and you take all your tablets that we give you from the hospital, your chance of having, if you don't take your medication, your chance of dying from a further heart attack is 6 times higher. Now, you know, you'll come out of hospital with at least 4 or 5 tablets, new tablets, after a heart attack. So you can imagine it becomes a little bit hard. Now the other side of the coin, because you're saying, well, this guy, he loves his tablets. And I do. But there is a but, as there always is in medicine. So adverse drug reactions. So, you know, somewhere about 3% of all hospital admissions to Australia are due to drug reactions or drug problems. So 7% of all emergency or presentations to the emergency department, 12% of all admissions to the medical wards. Now, when you start talking about people who are getting older, what do you think happens? It gets worse. So between 15 and 22% of all emergency admissions for older people are related to adverse drug reactions. 1 in 5. So, you know, that's a big thing. Now, the big thing here, between 1/3 and 2/3 of all those problems could have been avoided with a little bit of thought, partnering and discussion with patients and the GPs. So, and their specialists, but not without the specialists. So, 190,000 medication-related hospital admissions occur in Australia. It's a lot, isn't it? I mean, can you imagine? I mean, it's costing the government $660 million. So, on one hand, if we don't give you enough medications, we're going to cause you know, expense for the government by complications. If we give you too many and we don't get it right, we're going to cost the government too much money. We're going to cause you problems. So this is why it's so fun, so great being a GP, because we're in the middle balancing. That's what we do all day long. So, interesting enough, if you talk about, someone mentioned oncology today. Yeah, 74%. Oncology is you know, people who are treating people who have cancers. 74% of all patients who are under the oncology people were related to the medications that they were given by oncologists. 74%. Now let me say, I'll defend them a little bit. They are dealing with really harsh medications that have really quite substantial side effects, which is a little bit different to what we're talking about with diabetes. But the thing that amazed me, about half of them could have been avoided by either telling the patients or informing the GP or doing something. So where I'm coming with this is that prescribing medications, there's a whole lot of responsibility that goes with it. And I'm trying to work out where that responsibility lies. Royal Hobart Hospital, 30% of all admissions over 75 years of age was due to medication mismanagement. I mean, you know, it goes on and on and on. So, you know, certainly, you know, as we go up in the number of medications people take, the problems do get worse. And so there's always this balance. So, in general practice, we think there is over 300,000 adverse drug events every year. I mean, it's a lot, isn't it? I mean, now, so what can you do about it? So, for me, and see, this is really interesting, because when I first did this talk, I was going to talk all about the benefits of having stacks and stacks of medication. I'm sort of coming around to talking about where does that responsibility lie in terms of using your medications wisely and appropriately. Now, I'm one of these people who believe in a shared model. Now, part of my fear is that pharmacists, our community pharmacists, are being devalued. Right? Because I look on a pharmacist as being very similar to a GP. Often have a long-term relationship with patients. They get to know them. They get to understand what they're taking, why they're taking, look at the changes, and so on. But a lot of the pharmacy models now have people come in and out in very short stints. We have pharmacy warehouses. So, and even our, what we call medication reviews, are often not done by the pharmacists themselves. So my big fear is that, you know, the pharmacist has a real central role in this. But at this point in time, that role is being devalued. Now, I'm not a pharmacist, so I can say this and say clear with a clear conscience. Now, the reason I'm saying that, again, they took some people with diabetes, they gave half of them some information about what they should be doing, how they should do it, what things that they should work out for. And look, this was just some of the knowledge that people had before and after. And one thing that really worried me, only 29% of people with diabetes knew what the signs or symptoms of having low blood sugar was. Now, low blood sugar is a really frightening thing for someone with type 2 diabetes. And it can lead to collapse, it can lead to heart attacks and car accidents. So you've got to know what it is. And yet here we have only a third of the people who could actually tell that. 2 minutes? Okay, well, you watch it, I'll get there. So, anyway, so what these pharmacists did, they actually sat down with patients, talked to them about the medications, talked to them about a disease, very much like what we call our home medication review. Now, has anyone in this room had a pharmacist come to their home and go through their medications?
Not at home, we submitted lists.
Okay, fantastic. So, really, what it's about is getting the pharmacist, the expert in drugs, to sit down with you, to talk about what it means, why you're taking them, and how they all interact. Now, doing that, they were able to improve the sugar control in people with diabetes, able to lower the cholesterol without any increase in medication, just by taking the medications properly. So, some of the telling stuff, we have some great data coming from DVA now, Department of Veterans Affairs. Doing things like home medication reviews can reduce the risk of going into hospital by let's say by half. Yet only 5% of veterans actually have a home medication review. I mean, so again, we have this huge gap. We have ways of dealing with this, but it's just not being implemented in a systematic, sustainable way. And I'm sure you're going to say that's the same for all things to do with the government, but yeah. And even with things like warfarin, having a HMR led to an 80% reduction in hospital admissions. Now, warfarin's tablets we use to thin the blood, to prevent strokes. They have to have regular blood tests, can be affected by medications, can be affected by what we eat. So understanding that is really important. And again, you know, less than 5% of the veterans are actually having HMRs. So, you know, there's a huge gap there. So what do we need to do? So we know the number of drugs people will be taking is going to go up. You know, we're getting older, we're getting more conditions, as Kerry's been telling you. So yes, we're all going to be taking more and more medications. The cost to do that is actually going to increase. And in fact, there was a prediction that by 2020, diabetes was going to bankrupt Medicare. So if you pay more taxes, you know why. But what I'm saying, and this is what I'm after, is that I think there's really, what's missing is a really coordinated approach to responsible medication use. Okay? And I think that's at both patient, pharmacist, GP, specialist, and practice nurse area. I mean, there has to be far more collaboration than what we've got to do. And, you know, certainly I think that's something that we need to focus on and get right, because you can see the cost of not doing it right is high in terms of complications from, you know, our conditions, but the cost of not doing it right from the complications of what we give you is also high, and there has to be a nice balance. So on that note, happy to take questions. if you're game.
Hello, that was really very interesting. I could relate quite a lot of it to my mother.
Can't hear.
I'll repeat it. I'll repeat it in a minute.
My mother passed away from kidney complications after diabetes, blah, blah. I found in my visits to the specialists with her that she didn't want to ask any questions. She's of a generation where the doctor was the person who knew everything, and it was not respectful to question anything. And I'm wondering if, over the years, if that's going to change, and that might have an impact on some of the figures.
Look, certainly this is about GPs having a position of respect and patients not being able to, so that they can ask questions. Certainly the young generation coming through, certainly told that they need to engage with patients more, and actually give them permission. So I actually encourage my patients to make lists of problems, because I think it makes it easier for them. And I'll always ask them, so what do you think? You know, like I had a guy the other day whose cholesterol was high, diabetes was high. I said, oh gee, you know, have you guess what, I'm going to have to put you on more medications. So I said, but look, let's tackle one at a time. Which one do you want to tackle, your heart or your diabetes? So you actually negotiate with them. I said, look, from my point of view, the heart's the big thing, so I'd like to do this. And he said, no, actually, I think you're right. I'd like to do this, and then we'll see what we are. So I think you're going to find GPs and nurses are going to be negotiating a lot more about this. But yeah, there are some still, the old doctors who, you'll do what I say, and that's how it works.
I'll go to that table and back to you, Lorraine and Wendy.
I would just like to ask you about drug-related admissions, and I think there's a very important factor left out, and I'd love your comment about this. And this is our change in our social relations and population, that a lot of these elderly people do not have the family structure anymore, and they may in fact believe that they are taking the medication correctly, but not remembering on the onset perhaps of early dementia that they've already taken it, and they end up in hospital almost every weekend. Could you comment, please?
Oh, absolutely. Look, this is one of the things that, you know, sometimes in a consultation, if someone's got early dementia, you may not pick up on it. But this is where I rely on the pharmacist, because technically when I prescribe something new or different, he's supposed to have a dialogue with the patient. Now, of course, the pharmacist has a record of every script. So he knows whether someone's taking too many or not taking enough. Okay, so, and certainly in that situation, do what we call that home medication review. When you get the pharmacist either go to the person's place or that person sit down with the pharmacist and they actually ask them, so, what are you taking? How often do you take it? Now, if they're getting muddled, there are things that we can do. There are now things called Webster packs. You know, blister packs with all your medications in, you know, breakfast, lunch and dinner. Mind you, after having all that, what we give, you might not want to eat, but yeah. But there are, I think pharmacists, again, are a missing link here. They can do so much.
There are not enough of these.
Yes, absolutely agree.
And then one more question after that.
My question is a hypothetical, doesn't relate to anybody living or gone. Looking at the new medical graduate coming out in year 1 after registering to practice, has that person had enough training during their medical course in order to prescribe, bearing in mind that prescription of one sort or another is the bread and butter and one of the main tools in practice? Take that particular person 20 years on. Obviously, they have learnt a lot if they are in continuous practice. They have learned practically. Is our continuous development program sufficiently focused for them to keep up with the new medications, not the stuff that the rep brings through the door, not the blotters and the inks, but have they got enough compulsory CPD, and whilst they're getting this increased knowledge on their own experience, do they have enough time? Many doctors see far too many patients in 1 week to be able to develop their craft. Just like you to comment.
Cool. Now, I can see about 5 issues in that question. So that was a question about early prescribing, getting GPs out in the community, whether the GPs are working too long, whether they've got too many patients, whether the CPD is sufficient, whether the training is appropriate afterwards. So, I mean, let me take, I mean, ongoing education is a real issue. Every GP has to get so many points to maintain their registration. But what's not made, you know, you don't have to do your points on everything in general practice. You can pick and choose what you want to go to. So I could do all my 120 points on diabetes. Now, what's the point? I know my diabetes really well, but I still have to deal with pregnant women, I still have to deal with young kids. There's no scheme that actually talks about getting education in every domain of general practice. That's where I think it should go. But now, in terms of prescribing when you first get graduated, all doctors now, before they become, hang up their shingle as a GP, have to do a registrar position. And they all have to do it within a supervised practice. Okay, so they can't actually practice solo until after 4 years. So by then, you would hope that they would have a good understanding, and their theoretical knowledge is really, really good. What they don't still have is that practical understanding of the interaction between people and the world. And that comes with time. So in another 10 years' time, they will be the best GPs ever. And then another 10 years, like me, you start to then go off the perch and not as good. But I mean, and that's with most specialties. When they first come out, theoretically great, practically not so. Next 10 years, they become some of the world's best surgeons, physicians, and then after that, they're just living on that reputation. There was one question, was that? Yes.
Oh, and yeah.
My question related to the question that's just been asked, is there any segment in medical undergraduate training or pharmaceutical undergraduate training which puts those two groups together and presents to them the importance of working together? But the question I wanted to ask was, my lack of understanding tells me that my body chemistry, specifically, is different to probably everybody in this room.
Absolutely.
How on earth does a GP work out whether what works for 50% of his patients is going to work for me?
Not like the answer, but believe it or not, it's trial and error. Because I will give you something, and I say, right, I want to see you in a week, see what your blood pressure is doing. If you get any of these, you need to come back straight away. If you come back in a week and it's made no change whatsoever, it's not working for you, let's try something else. And so it goes on. So it's a continual, you know, ring. And in terms of pharmacy and GPs working together, look, about 5 years ago, there was a real tension, and there probably still is, between pharmacy and general practice about who's doing what and when, a bit of a turf war. And that's actually led to lots of problems, and we need to start breaking those barriers down. So, yeah. Thank you.
All right. So I'm going to thank Ralph for what I thought was a fascinating presentation, but I'm going to move quickly into an area where I know he's quite passionate about, and that is the collective efforts across disciplines and across, if you like, the lay and the government and the medical sectors to solving a problem. I'm writing an article at the moment, which you'll see in the next Melbourne Graduate, about our collegium. We have these great minds of every age, from the younger, earlier career researchers doing research projects or courses here, through to those who are in careers, through to many of you here now have had amazing careers and influences and remain well networked, and you've got a lot of wisdom. Here, to me, is an example of a project we could almost all collectively work together on in some way to influence change. We could be promoting, for example, a greater focus on interaction between disciplines at undergraduate, postgraduate and in career, continuing through to continuing professional development programs. We could, for example, be very much supporting Ralph's very elegant and simple proposal for pharmacists to be involved before and following medication, home medication reviews, or in pharmacy reviews or the list submissions. We could all be doing our little bit because we are educated, we're not stupid, we can influence, and that can be like a little collegial thing that the Graduate Union does to support the work of Ralph in not only trying to do that for his patients, but if you follow this guy a bit further through his career, he's also trying to change medicine in a way. So it does get that cross-disciplinary approach. It does get better and continuing education. It is looking at the welfare of patients, but also the GPs to make sure they're not overworked, they're not getting too many patients, etc., etc. But I think that the simple project of us doing our own little bit, talking to our pharmacists, seeing what they do, getting them in touch with Ralph, could be something we could all do to support such an elegant solution, really. If you're happy with that, Ralph, I'll get everybody to phone you. You're off and running. All right. I think it's been a fascinating presentation, and please join me in thanking Ralph. Sit a while. Don't forget to come and look at and buy an emergent size, and grab people off the street for membership, etc., etc. Oh! I've got to give something to Ralph. I always forget. Yes. All right, he likes red wine, we're lucky.
Yeah,